All right, then I'll start today's evening event. So this evening event came out of a collaboration that Swiss Informatics has with Didas. Peter Janus came up in one of the Didas meetings with the idea of giving a presentation in Swiss Informatics, or he had some information that he would like to share. And this seemed to be the perfect situation or a perfect model for him to share this information and next steps for secure data stores in digital health. He's not alone in presenting today. We have a couple more people joining as well. So Peter Janus himself, he has 30 years of experience across the finance industry, in the public sector, and in applied technology. He brings a deep expertise in data modeling, data analysis, and large-scale international programs. He holds an MSc in electrical engineering and a PhD in computer science, and on top of that has an MBA from Hochschule St. Gallen. Michal Jarmolkowicz is also a Didas member, and he is the CEO of SwissSafe. He specializes in enterprise security architecture. He has 18 years of experience across banking and healthcare, government and education, so a very broad area. So he specializes in enterprise security architecture over this very broad area, as well as identity and access management and data privacy. He holds an MBA in IT and an MSc in secure IT and speaks regularly on Web3 and security topics. We also have a third presenter today, Jean Pierre Messerli. He funded his medical studies by working as a programmer. This was the basis for his many roles as company founder, board member, consultant, and project manager, which is quite unique. So this is a great combination of skills. And these combination of skills make him an expert in clinical data modeling. So we're also glad to have him here today. So I hand over now to Peter to give the introduction to what we are going to be talking about today. So Peter, the floor is yours.
Thanks a lot, Noah and team, for having us and for organizing all these things, which I know is a lot of work. So thank you very much for that. And before I jump into it, it's a rather interactive part. So we have a certain high-level timeline, but don't hesitate to ask questions. You don't have to leave it to the end. So you can also answer them in between. And before I jump into the topic, I say a few words about Didas. Probably most of you don't know what it is. So you might have heard about the Digital Identity EID, or SWIU as it's being called right now, which provides a digital trust infrastructure. And most people think about basically replicating the physical ID card, but this trust infrastructure can do a lot more. So they can, in simple terms, they can represent pretty much whatever is a plastic card as a so-called verifiable credential, which is nothing else than a signed digital record. And the purpose of Didas is to go into these other areas where the trust infrastructure can be of a use. And I'm going to show that in the next slide. So we are just in a transitioning phase. So Didas is about 3 or 4 years old in the meantime, and we have some horizontal and some vertical working groups, which are currently being transitioned into what we call the SWIU Launchpad. So SWIU is the new EID, and Didas is very actively cooperating with the SWIU team to carry on these possibilities. And on the verticals, on the horizontals, we have a technical group, we have a compliance group. On the verticals, we have the subject areas, for example, health. And my role is I'm heading up the health working group. So that's from the website. As I said, it's currently in a transition phase. So at the upper right, I'm basically driving the health activity. So that's basically the role of Didas and my position within Didas. And within this role, I was driving some of the health activities. So when we had this review of the electronic health record law, that was one of the first activities in this role. So we gave a feedback in this official, in German it's Vernehmlassungsprozess. And the second thing is we are trying to push activities and visibilities. We have quite regularly interesting speakers. So one of the activity is We are having webinars. We are recording these webinars, and you can find these webinars on the YouTube channel of Didas. So typically there's a full version, and we also have a short version where it's a 90-second version with the summary in there. So that's one of our activities. So it's rather informal. It's not very polished, but we rather try to have interesting guests and have a spontaneous discussion with them. So that's pretty much the role of Didas. I make it very quick. So if you have questions, don't hesitate to ask. I would rather like to jump into the Didas health activities. And the driver of today's call is actually something what started in 2024. So there are hackathons, and good friend of mine is organizing such hackathons. So I'm quite regularly attending these hackathons. And there's a GovTech hackathon. It's now the third round in 26, but there was one in 24. And basically a half a day before the submission date, we put in a challenge, and I'll quickly explain that in a moment. And as a lucky punch, we even won an award, but we try to be visible and to show the possibilities of what Didas is offering on these hackathons. And there is now another one coming up, and that's basically the main topic of today's presentation. And one of the introduction drivers of this 24 hackathon was the role of clinical data in a data storage. And as you know, today we are in an unstructured world of data. And in the meantime, I think pretty much everybody has understood it's not really helpful to browse through hundreds of PDF documents. So the next step is to have that on centralized servers. That's something technology which is available today, so we can basically buy it and install it and get it up and running. That's proven technology, but particularly in Switzerland, where people are quite hesitant to put data on centralized servers, you can also do that in a decentralized way, basically within a wallet, and that's exactly what this trust infrastructure offers. I don't go into the trust infrastructure today. There are lots of interesting other presentations about that, but that was a little bit our idea to show how that could look like. So we called that an EPR 3.0 or EPD 3.0 in German, and that was a little bit the idea of this 24 hackathon, and that was very briefly how that looks. We have QR codes. You will get the presentation afterwards anyway, so you can look at this documentation at your own time. But it was really the idea to have wallet-based health information in a structured way, as you would do that on a centralized server. So technically it's the same schema and the same structure. It's just a different technical platform where it's running on. And I was really trying to get this idea through, and I was definitely very lucky because we had, well, you have to pitch your challenge and you have to explain that in advance. And I had the wallet team of the official informatics organization of our federation, so they were interested in contributing, and they're really experts, so I'm not so close to that. And there is that three type of awards, and one of the award is actually the most advanced implementation. And the hackathon is 2 days, and in reality you're hacking from lunchtime first day to lunchtime second day, then you have to prepare your pitch. So within this very short period of about 30 hours, they put out a prototype. Of course, a lot of things were not full in reality, but it provided a really good way in demonstrating how this could look in the future. There is a short explanation video, so if you check out the documentation, you'll also find a short documentation video where you see the final pitch with a live demonstration of how that looked. I tried to convey that to potentially interested parties, so also to the Federal Office of Public Health. But as it happens to me as an engineer, so it was probably a little bit too futuristic, so maybe a little bit too far into the future. So I think they are still struggling with other topics. But the success of this challenge basically gave us an motivation to go for the next step. And as the next hackathon is coming up by end of May, so it's 28th, 29th of May, we decided to go in with more health-related challenges, and I'll give you a short overview what we are doing, what we submitted, and how this is being positioned. And that's basically the full picture. So I had that in my mind for the last 2, 3, 4 weeks. Basically yesterday evening I was able to get to put it in some visualized form. So the hackathon is just a small piece of a larger puzzle. And what you see is really work in progress. So the submission date of the hackathon was the 19th of April. We were informed on the 27th of April. We had Monday this week, we had the so-called pre-event where we got the briefing how these hackathons normally go. So it's really very fresh information. It's work in progress. I'll come to that, what the next steps are. But wait, the idea is, and that was basically driven by different perspectives. So in a first step, we want to have a simple showcase where we have a chance to get it up and running by third or fourth quarter of this year. And the hackathon is one important part, but not the only one. So we start out with the fire modeling. I'll come to the details of the respective challenges, but it's very important is to use standards, the modeling part. Then we have the hackathon, and based on the hackathon, we are aiming to have an app. I usually call it an app. It's a little bit more complex, but for the sake of this slide, it's an app. And then we are really aiming to find some investors, because we're doing that in our free time, and you can only go so far with free time activity. So at some point you need some financing, and that's basically planned for the end of this year. And we have a very specific use case. It's the vaccination. I'll come to that. And the next step, that's in a very simplified manner planned for next year. We go through, once we have a blueprint, how that is being done, and Jean Pierre will say something about the idea. Then we use this blueprint to address other things than the vaccination, so medication and basically whatever is covered in the international patient summary, more or less the same process. Also aiming to integrate the electronic health record. If that is possible, we have some API interfacing challenges there. Having an advanced prototype, also looking for investors. And the third step is actually, and that's my personal ambition level, that's why it's called ambition. What I would like to achieve is a Swiss health app, which is as popular as the Federal Railway app in Switzerland. So the citizens have it, they use it, they like it, has a good usability. And on that note, the Swiss Railway app was actually created or initiated at one of these hackathons. So there is absolutely a chance to get that happening. And the third step, if you think about the data which you need, would be wearable data, so access to all these trackers which you usually have these days. If you think what the citizen want, they want their healthcare data at their fingertips. And they don't really care where it comes from, so you need to have it from the sources where the data sits. Same process again, an expanded app and investor search. So it's basically a 3-step process. It's an ambition. Honestly, I don't know if you're going to make it, but if you never try, you will never going to find it out. So that's just to position where we are. So it's not just a hackathon, it's much more behind it. And we have 3 challenges which we have prepared, and the QR code basically shows you our Google Drive where we have all these documents, so you can read through that. And that was the preparation material for this hackathon. And we have 3 cases. So the first one is the digital vaccination record. And the main purpose is really to demonstrate the interoperability through standards. It's FHIR and OpenAir standards, and that is driven by OpenAir.ch, where I am in the board of directors and also partially on the modeling group. The second one is the secure data store, which will be presented by Michal. So unfortunately, this one was not accepted as a challenge, but that's why I have the drawing before. We need it anyway, so we're going to work on it anyway. So not being on the hackathon doesn't mean it's not relevant. And the third one is actually a much improved onboarding, which is definitely a weak spot on the current electronic health record. So the title is a little bit catchy, so it's EGD in 30 seconds, but it's basically using the newly issued EID or SVU for a much improved onboarding process. So these are the three challenge hackathons. And the third one was also accepted. So we have currently 2 challenges which are part of this hackathon, and I'll show you how that looks like. There's an official web page which shows these challenges, so you can see ours are listed here. And what they typically do, there is a questionnaire, and they have so far uploaded what we put in this questionnaire. But of course, we have to do a little bit work to make it a little bit more understandable. So for the submission, you have to follow the questions. And now it's basically the idea to explain that in a little bit more. Formally, I'm the challenge owner of this one, but the actual expert is Jean Pierre. I think he's not available for these 2 days of the hackathon, and that's why I've taken the role of the challenge owner. But Jean Pierre is definitely the person who knows it much better. And so that's basically how it looks right now. That's uploaded from what we have published. As I said, that was made available to us on Monday, and we have now to work on it. And with that, I would like to hand over to Jean-Pierre to explain what's behind it. Jean-Pierre, thanks a lot for being present.
You can go back to the slide. Thank you, Pete. Hi, everyone. So as Pete already mentioned, this hackathon challenge is a joint initiative of OpenEHR Switzerland and HL7 Switzerland. The aim is to show in a practical way how 2 international healthcare standards can be combined to support interoperable immunization data management in the Swiss healthcare ecosystem. Next slide, please. Everyone is familiar with the traditional paper vaccination booklet shown on the right side. That's the booklet used in Switzerland. What we want to show is how a digital version can be implemented using international standards. HL7 FHIR and OpenEHR are best treated standards for this. With this showcase, we want to demonstrate how the 2 standards work together. HL7 FHIR for communication and data exchange, and OpenEHR for long-life structured storage in a high-quality data. Next slide. The showcase is designed to demonstrate the full life cycle of vaccination data. A healthcare professional documents a vaccination in his primary system. This information is exchanged with the vaccination platform using HL7 FHIR documents. For long-term storage, the data is transformed into OpenEHR and persisted as structured vaccination data in the clinical data repository. Later, a data consumer can ask for the vaccination record. This is transferred as FHIR document again. In this way, the showcase demonstrates end-to-end handling of immunization data using FHIR for exchange and OpenEHR for persistence. Okay, are there any questions or?
Obviously not for the moment. Yeah. Good. We got a thumb up. That is very nice.
Yeah, I have a question.
Go ahead.
Is obviously quite high level. So there must be definitely checks and balances and approvals of who can have the view on which vaccination records.
Yeah, correct.
Okay. Yeah.
So to as Pete explained, at the hackathon, you have 12 to 14 hours to develop
Right.
an proof of concept or minimal valuable project.
Yeah.
And what we out of scope is all the security layer and authentication, authorization. I
Right.
think first primary is scope is really on two standards working together. And until 2 years, the two standards, they fight it against. Every standard had the idea we are the best and the only in healthcare.
Yes.
And now there is really a big movement worldwide. We need both standards. Each standard has a has a scope. So HL FHIR is really to exchange. It was developed to exchange medical data in a structured way. And OpenEHR has been developed to store clinical information for a long time in a structured and semantic way.
Yeah. Okay. And the whole point is the interoperability between these two that have slightly different viewpoints or slightly different goals, and to make them play together.
So what's really important is the transforming. Huh? So you get
The
the
transformation,
HL7 document and you have to transform it without losing information to OpenEHR composition, store it, and then on demand creating the vaccination card and upload it as a FHIR document.
Okay, great. Thank you very much.
Maybe to add on this one, the focus is really on interoperability. So I'm in the healthcare sector for about 10 years, and the top pain point is the lack of interoperability. And interoperability is achieved through standards. The focus on this hackathon is really on standards to achieve interoperability. And we are fully aware that we need access rights, specifically in this sensitive area. But that's why I have this positioning slide. So that's done outside the
That makes sense. That makes fully sense. Yeah.
And on that note, I just today had a conversation with a representative of the Federal Office of Public Health, also last week, specialist in standards. And I'm really trying to get Federal Office of Public Health on board. And what we basically discussed, we have now this DigiSante program coming along, and one of his centerpieces is the Swiss health data space, which they're working on. It's not yet very much specified, as he's telling me, but the understanding is, and that's the most likely candidate, the data storage could be used for the permanent storage, and the FHIR is used to exchange data, and FHIR is actually designed for data exchange. So that's basically what we discussed. I also explained this idea of showcasing it, and he's very positive about it, because for most people it's very abstract, and I'm a big friend of showcasing it. And so if people can feel it and touch it, they have a much better chance to convey it. And that's what you're working on.
And there is also an European initiative. It's the European Health Data Space. And they just only use FHIR. They don't care about how to store data in a high quality way. They just define by law how to exchange data, and the Swiss health data space, they follow a little bit Europe. So with this showcase, we really want to show it needs two standards, not only a standard to exchange data doesn't make interoperability, because the storage of the data in a high quality, in a complete way for long life, maybe vaccination, you get the first if you are born, and the last in the year influenza when you die. So this data lives about maybe 100 years, and I think that there you need both standards, and that what Pete said, we want really to have a showcase that everybody can understand that this is really important.
Yeah, that makes sense. Yeah, transportation and storage.
And
Great.
the Nordics are at least 10 years ahead of us. So there is a trend towards open air in the Nordics. And if you talk to people who are working on that very closely, so they are sort of predicting that these standards will most likely converge in the future. But you have to start at some point to get experiences and then step by step improve it. Good. That was the first one. And the second one.
I have a question. Sorry for interrupting. First, just a quick question for the slides. Why is there the FHIR logo at the person registry? I thought we would store them in the other format, right? Did I misunderstand something?
There is
you
a
hear me?
specification. OpenEHR has a specification for the CDR, and you store only clinical data in the clinical data repository with the standard OpenEHR. Explicitly, no demographic data are stored in the clinical data repository. Really separate clinical data from demographic data. That's data protection. And so you need a demographic server to store or manage the patient name, first name, on and on. Mostly in these open platforms, you use an HL7 FHIR server, Happy server, something like that, to store the demographic data, first name, last name, birth date, on and on. And in OpenEHR, you have just an EHR ID for every person, and there's no demographic data, and that's explicitly and done for data protection.
All right, thank you. That was my question.
Good. So you're welcome to join the hackathon, and we're also going to document it live. So that's part of the hackathon. So these pages which I showed you, so this page will grow. So in the preparation, you'll see that in a moment. And while we are on the hackathon, we're going to document it. If I have time, I'm going to produce another short video which shows it. So you will see the results. And if you're interested, we make it very open, very transparent. If you want to contact us later, don't hesitate. Everybody who contributes is more than welcome. Good. So that was the first one. The second one will be a little bit shorter. So as I said, everything is growing very dynamically. So most of these slides have been prepared in the last days. So the second one is the challenge owner is Alexei Tikovic, who is going to do that. You can read it on the documentation. I don't, for the time being, have a lot more information about this one, but the idea is basically using the EID, which holds already a proven identity for the onboarding process. Today, you have very often to be in person, you have to show physical identity cards. It's improving over time, but the onboarding process for the current health record was really very difficult, which prevented a lot of people from actually doing it. And we just want to show that the onboarding process can be much improved. In the new law, unfortunately, that's still a few years away. With the new law, then it should be opt and opt out, meaning you get a health record automatically unless you explicitly refuse to get one. So that somewhere in the future that shouldn't be possible, but up to this point, just trying to make the use as easy and as simple as possible.
A question from my side. What does EGD stand for?
Das elektronisches Gesundheitsdossier. So we use the German term.
Yeah.
So it used to be EPD in German, so elektronisches Patientendossier, and it's now EGD. That was actually also part of our contribution. You should take out the patient because the whole prevention should also be covered by this dossier. And the official renaming is, I think it happened about half a year ago. So it's EGD, it's the former EPD in German. I don't know if there's an official English term. Probably I need to figure out to term that.
Yeah.
But that's
it would be good to write that on this page.
Yeah.
What EGD stands for.
Yeah. Once we expand the pages, we'll add a lot of links to all this relevant documentation in preparation. And that's actually a good segue to my next slide. So as I said, everything is happening very short term right now. So when we organized this webinar, we didn't even know if the challenges would be accepted or not. So it was a little bit a trial and error. So as I said, we will certainly need to amend our online publications. Right now, it's what we submitted. So we definitely need attractive descriptions. I wanted to put in sexy descriptions, but that's probably not politically correct. But it should be attractive to potential participants for this hackathon. Then we have an official platform, which is called Renku. I didn't know about that before this hackathon. So there will be a briefing on next Monday. And we're already planning to move on that platform. So obviously they have quite a number of services there, which we can use for the hackathon. So that's still yet to come. And the organizers of the hackathon will publish formal information on the 13th, so somewhere next week. So next weekend we have to update our representations and descriptions on these web pages. And the next step is we have to prepare for the challenge infrastructure. As mentioned several times, that the actual hacking happens from lunchtime day 1 to lunchtime day 2. So you don't have time to discuss or to install things there. Everything has to be ready if you want to get a usable result. So we have a whole bunch of servers and data and instructions and templates which we have to prepare. It's quite some preparatory work if you want to get something out of such a challenge with a fruitful contribution. The next thing is we have to prepare our pitch deck challenge. So the pitch deck's ready, so we have to present that on the morning of the first day. So we have to explain to potential participants what we are trying to achieve. And then on the morning on the 28th, we have to present that, and then basically we are physically present. So for those of you who are interested, I think there's a waiting list right now, but it's an opportunity to meet the real experts there. So Jean Pierre will be there. Roland Leux, who is the fire specialist, will be there. He's also the president of HR7. So it's really an opportunity to talk to the specialists. So that's a brief crash course where we are with our challenges. As you see, there's still some work to do. And so that basically concludes the first part of the presentation. The second part goes into the secure data store. Before I hand over to my colleague Michal, are there any remaining changes or questions for the challenges? A little bit overwhelmed, I guess. Yeah, we still have room afterwards. So with that, we are switching the presentations. I think also prepared very short. Michal, you can take over.
Thank you so much, Pete. Welcome, everyone, and thank you for the opportunity. Thank you to Swiss Informatics for organizing this webinar. Thank you for all the preparations to Pete and Jean Pierre. If Pete and Jean Pierre were talking about the standards and the storage, I will be talking about the control and how the centralized storage protocols can help, and how the Swiss SWIU infrastructure, the trust infrastructure, comes beautifully into the picture. The motivation is really what happened in the past, and with Pete, we've been very often talking about the minor Infogen and how insecure it was, and how this basically contributed to a shutdown of this very, very popular platform. I myself bring experience in this topic of the centralized storage of identity and applying digital wallets and those decentralized identity protocols to health, to tourism, to banking, many sectors. I have the privilege of working with the Swiss government. I found myself at the center of the digital sovereignty discussions that some of the articles you might have read recently. I'm very active inside DIF, pushing such standards as DITCOM for wallet-to-wallet communication and decentralized storage, like the one we'll be talking about. And the main expertise is in identity, so I'm a partner with many great companies.
Michal, could you
Yes.
move your microphone slightly away so that your breath doesn't make some static?
Thank you so much. Is this
Yeah.
better?
Yes, that's better.
Okay, perfect. Thank you.
Much better, yeah.
Great. So we'll be talking about the need for secure data stores in health. The current situation is that we have a lot of data islands that also create trust gaps because of the different ecosystems. There's a big gap that doesn't allow for efficient data roaming. We have visibility gaps, which causes really impact on some health decisions and our lives in the end. And this fragmentation in the end is not good for the security. I'm a security expert, and having a lot of fragmented systems is always not good from this perspective. And on top of that, there's the whole aspect of privacy concerns, and Meine Impfungen was one great example. What I want to share with you, will be a little journey from where we are today to where we can be very soon in the future, but also to how we can build a path to the agentic future. In the end, the motivation for this webinar is to bring other participants that would like to join us on their research. My motivation is to bring the expertise I have to the community, and of course, as Pete mentioned, we also hope that sometime in the future, maybe there's a business opportunity as well. But my main motivation is really to talk about those challenges, the security, the privacy, and contribute to an open community discussion. So thank you so much for joining, and we're really looking for partners. So the problem is that the traditional way of integrating services, including in health, really doesn't work anymore, really doesn't scale. We have those islands of data of service providers. Technically, we could integrate them. Like the problem is really not so much technical as it is with data sharing agreements, with cross-service automation. And in the end, some data that user has in one service is not available in another, those red islands that you see. And this pattern doesn't scale. And this limits, in the end, what service provider can offer to us, the effectiveness of the health services. The new paradigm is really the user becoming the API. So user being at the center with its wallet, like the SWIU wallet, and additional services built around the SWIU wallet to store data securely, privately, within the wallet, cryptographically secured, under full control of the user, and sharing it only as much or as little as is needed to get the best service. So full control of the user, services connecting directly to the wallet, like the SWIU wallet and the future versions and iterations of it, that allows the data to be shared with consent of the user, which solves a lot of those integration challenges, because technically we could share the data, but consent is a problem, allowing amazing privacy functionalities like selective disclosure. But one of the most, and I think most important elements that this brings is trusted data. And for me, trusted data means actionable data. So data which can be actioned on, medical decision based on which can be immediately performed. And this really unlocks the power of portable data that patients can bring with them, from very simple things like registering at the clinic to sharing some basic data, with things like just scanning a QR code with our SWIU wallet. It's really those simple interactions that unlock the data portability, that make the data actionable for doctors, and unlock process automation. But I also want to talk about the future and where this really goes, how this is fundamental for the agentic future, and how we need more than just that, more than just QR codes, and more than just the current generation of wallets. And this is why we need you, why we need research, why we need collaboration of the community to do something like you see here. So what you've seen in the previous slides from Jean Pierre and Pete is the standards like the FHIR, the OpenEHR for storage. What I want to talk about is the centralized web node technology, which brings control to that. And this is my very pragmatic approach. This was a real project I did in some other part of the world. where we've been building a few full agentic future based on wallet technologies, also for health. And in this future, which I'm putting my enterprise architecture hat, we have so much investment done already in current EHR systems. So what I'm showing you and what I want to share with you is really a very pragmatic view how we can leverage the power of our trust infrastructure to control the EHR, the health data that we have. And what we did in another part of the world is we didn't change the EHR system. They already invested in it, and it was not practical to assume that they're gonna choose a new one built fully on the centralized trust. Is there a question, or I'll continue? But
Nope.
Feel free to interrupt.
Just a comment.
So we very pragmatically, I assumed that the EHR system will stay. What we did is we just built a decentralized web node interface on top of it, which allowed the user to fully control what data is shared when they arrive at a hospital or a clinic, just with their SWIU. Sorry, that I'm showing SWIU wallet. In that case, that was another wallet, but based on exactly the same technologies like we have in Switzerland. So that's the future that I think really unlocks the security, the control. It was based on FHIR. It was working perfectly. And what it allowed is a user, when the user arrived, the patient, when they arrived at the clinic, to just scan a QR code. If it was the first time the patient was at this clinic, this automatically onboarded the patient. It allowed access to the EHR data. And you can fully control, is it only read access? Is it read and write access? Is it creating new elements? So this really created this control layer on top of already existing EHR system and investment. And now going to the future, how this overall ecosystem scales, you really need something like that to build complex interactions for the broader ecosystem of services. It works with the current generation of wallets, when you just want to onboard, if there's really a simple activity, patient comes, scan a QR code, maybe with this few wallets, shares EID, maybe shares a few credentials in the wallet to basically get onboarded or checked in at the reception. But when we're talking about the future, and especially about agentic future, we really need more control. We need ability to delegate. And I'm not talking about some imaginary future. I'm talking about future which is already now, because the big tech is taking notice, and they already built. It's not only Switzerland, it's really global trust ecosystem which is shaping through APIs that are already made available on our phones from both Google and Android. There's an ability to ask for trusted data from applications. So it would be already possible now for a health application to ask for trust data like EID or other health data as verifiable credentials from applications installed on the phone. It could be used for agentic system to automatically assist us with our health matters. And there's great standards also developing. I'm especially excited about the cryptographic consent algorithm. This comes from the payment industry, from the MasterCard working together with Google, where I can cryptographically, as a verified credential, record my consent. So I imagine a future, an agentic future in health, where I can record what I want to do or what I want advice on as a verifiable credential in my wallet, and ask my agent, hopefully running at the edge just in my phone, to take my data from my EHR system in the FHIR standard, share it maybe with my doctor in advance, or maybe even on behalf of me if that was authorized, to get just-in-time services exactly when I need it, and get seamless experiences in health. So really moving from those QR code generation to the future wallet-to-wallet communication with protocols like DITCOM, with protocols like the centralized web nodes for the centralized storage to enable health service providers to communicate with me, represented maybe by my agentic system. This creates another great opportunity to close the trust gap in the IoT. Once we already have those standards working, if we build on the trust infrastructure, if we use standards like DITCOM and decentralized web nodes, we can start closing the trust gap with IoT health devices. Current generation of devices come usually with PKI. They need specialized onboarding. That companies will charge hospitals to onboard just their IoT devices. But the reality is that 95% of what's being done behind by those companies, and they're charging hugely for it, is exactly the same. So if we would enable those devices to also come with their own identity, this explodes the potential of what can happen even more. And we can have a really connected, agentic, just-in-time health services in the future if we start building on those DIT-based technologies. And DIT, amazingly, is exactly the technology that Switzerland chose. If you compare to Europe, which doesn't use DIT, this really creates a great opportunity to leverage it. So I personally envision an open, decentralized approach based on DITs and technologies for communicating and storing data control based on those DIT protocols. If devices come with their own identity, it really unlocks an amazing future. So now about the opportunity again and call to action. The secure data storage protocols from DIF are looking for new owners. It was a protocol which came to existence with great contribution from Jack Dorsey, the founder of Twitter. I had the pleasure of working with the team and implementing this across health, education, and many other sectors. And this is a call to action for you to join us on research initiatives. We're really looking to take this discussion forward and define what those standards are for Switzerland and maybe for the world. We're looking to work with you on topics for PhD, for masters, for bachelors. And the hackathon is just the beginning, as Pete said. And for me, it's really a community mission to bring this decentralized, privacy-preserving future to Switzerland and maybe become the something that the whole world could follow. Pete, you want to add something from yourself?
Well, just re-emphasizing the point, it's really an opportunity for Switzerland doing some research in this field, because Switzerland, with its neutral attitude, is most likely the best suited country in the world to provide such a service. And that was some of our agenda items. If there is somebody out there to revive this working group and to provide some scientific search where we can prove that we have a scientifically backed security, specifically in this minor implement case, because the functionality was much appreciated, but the security was just not where it should have been. So that's really the call to action, because we want to get it off the ground as a demonstrator in this year. So whoever from the scientific area has interest in that, has PhD students who would like to contribute, publish also on this topic, that would be very helpful. So just re-emphasizing this point. And I know I discussed it with Ernst before. I know Ernst has a pretty strong opinion there as well. If you would like to add to this topic, Ernst.
Yeah, thanks a lot, and thanks, Michal, for this presentation. I think I have two things to. I agree with Pete that it is an opportunity now. Hold on. Just based on the fact that we're so far behind, and we are just restarting again the whole discussion about the electronic health dossier, and we are rewriting the law. And so my first question is to Michal. I mean, this, sort of personal data store, this wallet could be my electronic health record, right? My personal electronic health record, not the one in the hospital, but the one that I have, the EGD, as a wallet that I have, whether it is now physically or whether it is connected like in your service, but that would be a central point. And we're talking here about health, But we have an initiative together with ETH on education, where every child gets an education wallet, where all the things she or he does is stored in her wallet. And this is extremely sensitive, and it only belongs to her and to her parents. And so we have exactly the same discussion there. And so that is the one part. And the second part is the other thing that Switzerland has to offer is this Adrian Perix, we talked about the SION basic internet infrastructure, which is unique for Switzerland. It's used by the Central Bank of Switzerland. It's used by the Secret Service of Israel and so on. I mean, we can combine these things, right? If you can comment on both the personal data store, the EGD, and on SION, please.
Thank you, Ernst, for those great questions. So I'm a pragmatic person, and I advise my clients on near future and then later future. So the ultimate goal, the target architecture is exactly what you said. The target architecture in this proposal is the DWN in the middle becomes the EHR system, and you have all your data under your full control. But the pragmatic view is those EHR system already exist now. And we can already now bring control if we just add the DWN interface on top of them. It's sometimes terabytes of data, and finding a good way to the future how those terabytes of data are under my control, when they are stored, where they are replicated, is a challenge in itself as well to discuss. So just starting tactically or near term with the DWN as an interface on top of existing EHR, and then with time moving to full decentralized EHR is exactly the goal. And to the second question, if SION is the B2B protocol, what we're showing here is basically a B2C. So how a user can fully securely communicate with health providers and have their data under full control and exactly know where the data flows. That will be like a SION analog for a B2C, exactly. And we're really looking forward to find partners that will be interested to do research with us. And I hope you find this an exciting opportunity.
Well, if I can add something in here, because exactly. If we're talking about SION, I would be interested in understanding more what you mean by using SION in this context and how it would help. Because I will have the course with the professor who created SION next semester. So I might be interested, but I don't really understand. If you can maybe elaborate more on that part. Why is SION in this particular case an important internet protocol that you would like to choose over the IP normal one?
So SION is an amazing development of Switzerland, and I'm really, really proud of what ETH team done there and make it really practical and implemented not only by banks, but also by already health institutions in Switzerland for B2B communication. Spending many years myself in PKI, I really appreciate the architecture there. I studied the articles and I read the book that Adrian wrote. I recommend everybody that's interested in cryptography to have a look. It's really amazing how basically it changes the current situation with internet, where you send some package and you just hope it arrives, but you don't know if it goes through China or wherever before it arrives, to have really control. So I'm excited about the expertise we have in Switzerland and how it could solve some of the challenges for the banks to make sure that our bank data doesn't flow through China, that our health data doesn't flow through China, or other places we wouldn't like to see there, with full control. And and this is another set of protocols. The SION is just a nice analog of what we could do for B2C. So I'm not talking about applying directly SION here, but applying the expertise and the same fundamentals to have full control based on credentials, based on cryptography over our health data, where it's shared, but using those DID-based protocols. So using the investment of Switzerland in the SWIU trust infrastructure, I believe we're spending like 300 million to build the trust infrastructure based on DID, decentralized identifiers, and now building on top of that. So if you compare SION builds on top of PKI and certificates, to, in the end, deliver this trust for the internet traffic. Here, it will be building on top of the decentralized identifiers. So each SWIU wallet has a decentralized identifier to deliver this trusted communication of data and control for our health data, but in a B2C scenario.
So let me connect that to the comment that Pauline made in the chat. She wrote, "Hi, good evening. If you speak about wallet technology and decentralized web nodes, does it mean that this is based or built on a blockchain?"
And that's a good question, and it's not. I'll have a quick answer. So we're talking about the SWIU trust infrastructure that is coming live in December with the EID and the decentralized identifiers and the cryptography there. So this has nothing to do with the blockchain. I was in a project where on top of what you see here and what we're discussing, blockchain was also discussed. So for example, if I have data in my decentralized web node, and maybe I want to monetize this data, to sell this data for research, that blockchain could use to basically control and monetize this data and have something which is called like streaming payments. So if it will be really future stuff that I will be talking about now, but this is really considered in some parts of the world. So if I have my data, I could contribute my data for AI research. Some AI models are trained on it, and I maybe are not paid when this is happening, when the model is trained, but through power of blockchain, I can be paid each time the resulting model is used. I can have streaming payments, like really like cents every time a model is used. I can have streaming payments with blockchain back to me. So in some way it connects, but blockchain is really not needed for anything we've been talking about today. But there's amazing opportunities there. Once you have control over your data, how you can potentially monetize it with blockchain.
Interesting. Pauline, does that answer your question? I think it was a very good question, because I had the same similar question, similar thought. Okay, great. Thank you for asking that question, Pauline.
Thank you.
Yeah, thank you for the question.
All right, we have another person, Sonia Duke, who's also co-organizer of events at Swiss Informatics. She has a question as well.
Yes, thank you, Nora, and thank you for the presentation, for both presentations. That's very interesting. So my question is not a technology question, but more a people process question. You mentioned at the beginning when you're presenting and you're talking about the medical data and how it is stored and scattered on different service providers, that this one of the non-technological challenges is this sharing of the data. So now in this new architecture that you provide, it looks like this has been delegated to the user. The user is the one that decides on how data is shared. But I mean, there are use cases where this data sharing is very fast, like to do it. You go to repair your car, you know that you need to give the information on your related to the car to the car garage. But for the medical data, this is much more tricky, So my question is more like, what type of educations or how are the users helped to decide on what medical data should they share with what institutions? That's one question. And maybe one provocative one. What happens, or is there a process put in place when you have like a medical emergency and when it comes to data sharing? Thank you.
Great, amazing questions, and they really come with experience, that you realize that those become some challenges that need to be addressed. So the first one, I'll return back for a moment to simple use cases when it's just opening, to kind of expand on your question, when it's maybe just checking in at the health institution or maybe first time registering there. I come, I scan the QR code with my SWIU wallet, I share my EID, I understand what's happening. If it's like this situation in the future, I'm not understand what's happening there. And there's no way, when there's hundreds of those interactions happening, maybe tens a day, that I'm clicking through accept, and reading and understanding what's happened, especially when I may be under some distress, there's an emergency happening and like that. So what became obvious in the practical projects, we really had real projects. This came very early, that as this scales, you need some help. And my vision and my approach was that there's basically an agent running at the edge, at the phone ideally, on my device, or my agent in general, that is trained to advise me. And I basically set only some preferences, what I'm comfortable, what I'm not comfortable with. So we integrated in the wallet some technologies which went through the user agreements that nobody reads and gave suggestions to the user. You know, based on your preferences, we advise you agree to this or not. You can change it, you can go into the details. So I really envision that it starts with simple wallets and QR codes, but we really need agentic wallets in the future and agents that are helping us understand the terms and conditions. Currently, people don't even know that their health data is being used in medical research in ways that if they knew, they would immediately, not agree to. And we have also nearby many examples of that. So that's I hope answers your question, and I'm really hoping for agents running at the edge. When I've been starting working with this like 5 years ago, it was tricky to have a model, AI model running on the phone. Now it's really possible if you have specialized agents, models specialized in fields like advising you on privacy, you can feed them on a phone already now. And those wallets are coming, and that's also my expertise where we help build them to some clients.
Maybe I can add a little bit more a pragmatic approach. If you think of today's world, the electronic health record as it has been planned, the use case for the electronic health record, EPD in German, it's not if you have every 5 years a flu that you enter your medication there. That's not the real use because it's either chronic diseases, multiple chronic diseases where you have hundreds of paper documents today, or you have severe injuries. So typically situations where you have multiple physicians for the treatment. And in the past, it was your family doctor who was usually your fiduciary for your healthcare data because the path was very simple. So you went to your family doctor, and the family doctor, if it was necessary, gave you an admission to the hospital, and there was basically not too many players. Today, if you have so many specialists, your personal health data is spread throughout a number of systems. And in the practical world, a good friend of mine unwillingly tested out the system. He had a bad injury, and today's reality is you're walking around with a suitcase full of paper printouts from all these medical records which you have to have with you. So in German, the patient is the Datenträger, so that fits quite nicely. So he's basically carrying around his data in a physical form. And the very first step of the wallet, before we even can think about agents, is we have to have the data associated to the person. It has to be person-centric again, which was the case for a long time, as long as it went through the family doctor. And that's the very first step. And the second important step is to have it in a structured form, because if you have hundreds of PDFs, no physician will open and read that. Well, he just can't do it. I wrote the prototype long before ChatGPT to get some reasonable information out of these documents, just to put it on a dashboard. So step one is really to have it person-centric, again, have it in a structured form. And to have it in a structured form, you need to capture the data in the highest quality form at the source. If the physician misses something in a document, if you let AI analyze it, either it cannot add this information because it's not there, and if you force AI to say something about it, it starts hallucinating, which is not what you really want, specifically not for important medical treatments. So it's the idea to make it person-centric again, and that's what we tried to show in 24 hackathon challenge to how that could look like. So check out this short video, which gives you a live demo how that could look like. And then step by step, the more we have the information person-centric and structured, then we can let AI and agents run over it. So step one is to get it in a reasonable form, actually. I hope this helps a little bit to understand.
Yeah, all very interesting aspects. Maybe I add as well to what Michal said about your data being exactly from this page, your data being shared, even though you don't want it to be shared. There's also the flip side to that we had when Ernst Hafen and Elke Mittendorf presented, it was 3.5 years ago at Swiss Informatics, that maybe you want your data to be shared more than it is now. For example, somebody who knows that they're dying of a disease and they would like experiments to be made on themselves, and they would like to share that information as well. So then you could instruct your agentic AI that you do want your information to be shared, to go out and find people who are doing research on the disease that you're currently suffering from, so that they also have results from experiments that you're allowing. Now, maybe Ernst, would you like to say something about that? And how do you see agentic AI solving that problem that we discussed 3.5 years ago?
Well, as I said before, I think the fact that we're so far behind and we can basically restart the system with and build it just like Michal now presented it with agentic AI and AI in the background. Even my EPD today with 50 PDF documents becomes alive because I can run AI over it and visualize all my hard documents in an instance. And so even the old EPD that a few of us have is not just a PDF grave anymore. It is actually more. And we can build on that. That's why we're also doing this challenge at the hackathon with making it easier to open even the existing EPD and using this. And we have another project also with Aljaksai Ticovic, who has built an EPD bridge for doctors that are not connected to the EPD to send documents directly to the EPD. So all this is possible now because of Cloud Code, because of agentic AI. And so we can really move quickly, but we have to share a common vision, which is unfortunately not shared by many people in the BAG, because there are so many interest groups that profit from the inefficiency of the current system. And so you really have to go around them in somehow. And to make the benefit for the patient, as Pete said at the beginning, with a Swiss wallet that's as attractive as Twint or the SBB app, right?
Yeah, well, maybe people will be happy if they don't have to give their information and fill out forms every single time that they do a step in the medical procedure. I had a small medical procedure a little while ago, and every time I had to reiterate everything I said. And as Michal said before, if you're under stress because you're getting closer and closer to your operation, you're getting more details that you don't really want to know about, you start filling out these forms worse and worse. And I had forgotten that I'd had a wrist operation. I didn't tell them that because at that point I was getting more nervous. So maybe people will see the advantages of not having to repeat all of their personal data every time that they take a step in a medical procedure.
And on the other side, I can give you a very specific example of a good friend of mine. He had a very rare allergy and he was suffering for many decades. So he was feeling unwell and he never knew where it came from. And then finally, after about 30 years or so, he spent the full week in hospital where they did all these allergy checks. Imagine if you have your healthcare data and probably your genetics in a structured form. And he told me he is one of less than 10 persons in Switzerland with this type of allergy. Of course, his practitioner doesn't have the knowledge to find it out and ask the question. But if you have AI who finds all this data in very short time, then if you have some initial indications, you can then put some follow-up questions in there to narrow it down. And the physician, in combination with AI, can ask specific questions and initiate specific tests where you can identify the problem much quicker and much easier than just trial and error for many decades.
And then you can share your personal information with other people who might also have it, and you might have tell your agentic AI, I want to share my information because I have such a rare disease. I want other people who are suffering the same to profit from what I have learned.
And interestingly, there's an interesting book called, I think it's called Pirate Healthcare or something like that. And these are actually communities who are suffering from rare diseases, which are not relevant enough for the pharmaceutical industry because there's just not enough profit around. And they have exactly this type of self-help organizations. And I need to think about the title, something like Pirate Health or something.
Very good. Are there other questions from the audience? People have some more comments. How does that feel like to them? Is it scary or is it inspiring? Anybody? Yeah. Oh, we see some clapping. So people like the discussion topic and the direction things are going in.
Hello. I will allow myself. Sorry, go ahead. I didn't hold up my hand, so you go ahead.
Okay, I'm on the phone, so I don't know if I even have my hand up. So thank you for this organizing this webinar. I want to ask, how do you see the trans-border commuting workers, so les frontaliers, the grensgängerinnen situation, who might not have a Swiss ID, but might have either healthcare here or some form of care that involves medical professionals? How do you see the challenges in having a patient? No,
and they would be working in Switzerland? They would be working in Switzerland.
Yes.
So they would have to have.
That's exactly the idea why we are pushing for the international patient summary. If you look at the specification, the international patient summary, and that's the reason why we need to have structured information. It's coded. Let's assume you are in Switzerland with a Swiss physician, and then you go to a safari to South Africa where you have a different language. Even if you would have your records with you, the person could not read it because it's in a different language. And the international patient summary is exactly that. So it's structured information. There are allergies, there are medications, there are implants. And so the most important things, you can Google for international patient summary. It's very well specified. And that's exactly the idea, that it's the minimal health information which is cross-border. And the World Health Organization, WHO, is actually pursuing this international patient summary. And here comes the fun factor. This thing is specified for so long. About a month ago, a colleague told me about Claude, and I'm coming from the programming side. So I did it. I did some programming recently, and I was spending weeks actually in struggling with incompatible code libraries. I didn't do it for a long time. So I finally gave it up. And then said, okay, give it a try. And it took me, believe it or not, it took me 30 minutes because this international patient summary is so well specified. There was one single prompt. I told them, create the prototype for international patient summary. I also specified on which target platform. It's Flutter, which is the Google cross-platform development environment. So you can have it on Android, you can have it on iPhone, you can have it a web solution, you can have it on a Mac. Generated fully automatic. So with this single prompt, it generated a solution. It even asked me if I would like to include certain elements, if I want to have it in it, or asked me if I wanted to have some test data. And finally, it took me more time to install this Flutter on my PC than getting that done. Interestingly, it ran into the same problems which I had. It had initially had these incompatibility problems and compile errors. Told him, check this, check that, recompile this. But within 30 minutes, I had a running prototype. And if you know the international patient summary, it has nice colors and nice icons. Everything was found. It was in the right colors with the right icons. And that's actually what we are planning to do on the hackathon. So that's this new type of vibe coding. So you are not just 10% faster, you are 10 times faster with these technologies.
So she's identified then another group that would be using this interoperability and interoperable healthcare. So that's an excellent comment for your side. Is Florina who made the comment? Yes. Thank you very much. Yeah. Go ahead.
Thank you as well.
All right. There was another person who also was asking a question.
No, it was actually me jumping in. I didn't want to ask a question, but I really like the model that we just saw before. And personally, I really think there's a big need for this. And in terms of, yes, exactly. Data safety, this at least appears to be also, from what I understand, to be really the perfect model. And indeed, it could be copied, as you said, Peter, worldwide, because interoperability plus data safety, plus it being steered by the patient, patient saying who gets the data and who doesn't, and being the owner of the data. I think that's exactly a need that is, it's a worldwide need. And I don't think that anyone has a response to that yet. And even I think even the Nordics countries, while they are far ahead of us, they may not yet be what this picture shows, right? At least that's from my knowledge. So thank you very much for this extremely interesting presentation. And
thank you, Pauline.
Quickly talking about this cloud, I did even a short video. I was so surprised that it worked so quickly. I'll send it to you, Nora. So you're publishing it on YouTube. You can add the link, then you can check out the video as well.
Great. Are there any other questions from the audience or comments, input? If not, then we close on Pauline's comments. So thank you very much for your positive comments. Thank you very much to the presenters. The call to action, there are two here. Then one is this research opportunity for PhD students and for doing research. The other one is to join Peter's hackathon. And as you saw from Peter's slide as well, this is a long-term project. So let them know if you're interested in joining in the long term, even if you're not interested in one of these ones, but just to continue working on this one. As we've all seen, it's a very important part. So thank you very much again, presenters, for this excellent presentation that is very important to all of us and also to our children and the future generations. And interesting how we can leverage AI and agentic AI to make this work much better than it has in the past. So thank you very much. And
thank you so much.
All right.
Thank you, Nora. Much appreciated.
All right. Goodbye, everybody.
Bye.